Hi, I'm Andrew Kuykendall from Moffitt Cancer Center in Tampa, Florida, where I focus on the clinical research and treatment of patients with myeloproliferative neoplasm. And I'm joined now by my esteemed colleague, Jyoti Nangalia. Jyoti?
Hi, my name's Jyoti Nangalia. I'm a hematologist and a scientist based in Cambridge, UK. I treat patients with myeloproliferative neoplasms, and much of our research focuses on why these conditions arise and how they evolve in patients. So, Andrew, if I start by asking you to explain for the patients, what are MPNs?
Yeah, so MPNs, we use a lot of abbreviations for these because we've come up with very long names to describe them. So myeloproliferative neoplasms. Really, when we talk about myeloproliferative neoplasms, we're talking about three kind of classical MPNs, which we have abbreviations for as well. So essential thrombocythemia, ET, polycythemia vera, PV, and myelofibrosis, or MF. And these are really diseases of the bone marrow that are characterized by overproduction of blood cell making, if you will. And so while they're similar, there's really several key differences that distinguish between these disease entities. And so ET is characterized by too many platelets in the peripheral blood, and the bone marrow looks relatively normal, except for there's too many mature megakaryocytes, which are the cells that are producing these platelets. Polycythemia vera, or PV, is characterized by too many red blood cells, although it's not really a disease of red blood cells. It's a disease where there's overproduction of many types of blood cells, but the red blood cells tend to characterize the diagnosis. And so we often see too many red blood cells, a high hemoglobin, a high hematocrit, but oftentimes there's too many platelets and white blood cells too. And the bone marrow here looks like it's an overdrive. So there's too much cellularity, too many blood cells being made, as you could imagine with having too many blood cells floating around in the peripheral blood.
Sorry, I was going to ask, why are these conditions considered cancers?
Yeah, so it's a great question, and really, what drives the kind of thought process that this is cancerous is these are driven by mutations, right? These are driven by acquired mutations in the blood cell machinery making that drive this overproduction. So they kind of push that gas pedal on, if you will, and instead of making blood cells when it's appropriate, they're making them all the time. And so I liken that to if you had a colon cancer or a breast cancer or something, you would have too many breast cells or colon cells being made, and that would lead to a polyp or a mass. Unfortunately, with blood, rarely do we get masses of blood. Those masses of blood show up on our CBC, where you see too many of those blood cells floating around. And so it's a little bit different than solid tumor cancers to think about, but in general, it still drives from that kind of dysregulated overproduction driven by an underlying mutation.
And when you ask someone about a blood cancer, people will often think about a leukemia. How are these different to those cancers that people may have heard of, such as, you know, acute leukemias?
Yeah, so I think the big difference between acute leukemias and these which are more chronic leukemias are you're making functional blood cells here. These are blood cells that work. They do what they're supposed to do. And as opposed to with acute leukemia, we always characterize that by a percentage or a number of blasts. And these are really just very, very immature blood cells that are not functional. And therefore, oftentimes the treatment and the approach to those diseases when you don't make functional blood cells is you have to reverse that process quite quickly, or else the body's not going to work. As opposed to these chronic leukemias, when you make functional blood cells, oftentimes they do what they need to do, but they come with other risks, and that's where we focus our treatments.
So it sounds like you're making more blood cells, but many of them do what they're meant to be doing. So does that make these conditions life-threatening then?
I think it's a great question. I think if you look at just overall life expectancy of patients that are living with MPNs, ET and PV, certainly there is a decreased overall life expectancy with these diseases compared to age-matched controls, but it's mild relatively. And so we still have a goal in mind of having patients live a long and healthy life with these diseases, but certainly patients with ET and PV are at risk for cardiovascular events, maybe even disease progression to a smaller degree, and that can certainly impair those goals. Myelofibrosis, on the other hand, I think there's a more clear relationship there between the disease and a decreased survival, but even that is what we call heterogeneous, meaning it differs from patient to patient. Patients with low risk disease may have a relatively normal life expectancy, while patients with high risk disease, that may not be the case, and the survival can be quite poor. And this can almost mimic a more acute leukemia, but a lot of that comes down to the genetics of the disease and the ability for the bone marrow to continue making normal blood cells.